Okay, so on the first specimen, it's kind of a white specimen. I am not sure. Well, our topic is intestinal stuff, right? Intestinal cancer. So we can guess that we're either in the small or large bowel, right? So if you guys had to guess, which one would you think this would be? And here's what's this? What's this right here? So polyp. So where are polyps more common? In the colon. So yeah, so this is the it says it right there. Ah. Okay. So how would you describe this? If somebody had to use some words to describe this lesion, how would you describe it? Sessile, that's right. It's arising from the surface, so it's kind of a polypoid projection directly from the mucosal surface without a stalk. Okay. And just from looking at it this power, it looks kind of similar in color to this uninvolved mucosa, right? So as far as we can tell grossly, it doesn't appear to be horribly ulcerated or anything like that. So, would this be, so what kind of a polyp could this be? What are our options? What's a colon polyp? What's the most common polyp in the colon? Right, a tubular adenoma, I heard it. So, we would say that this one is at least low-grade dysplasia, right? Now, we don't have any marker here to kind of compare how big it is. But what if I told you it was kind of a big one? What if I told you it was probably a couple of centimeters? Right, so it would probably harbor high-grade dysplasia, maybe even carcinoma in situ, maybe even some invasive carcinoma in there, right? Okay, so that would make it, if it harbored those things, then it would clearly be premalignant, right? Okay. And we cannot tell just based on gross appearance, tubular versus tubulivillus, but we talked about how a villus polyp kind of looks like an owl plant coming right off the desert floor, so kind of just fingers coming up. So this one could be that, but probably not. What about symptoms? What kind of symptoms might this patient have? Maybe a little bleeding, maybe, but usually they're just asymptomatic, right? Usually nothing. It's not obstructive. It's not secreting anything, making the patient have diarrhea or anything like this. How would you treat this? How would the patient be treated? Looks like they've removed it, right? The whole thing. So you would try to do a little polypectomy if it's so big that you cannot get it out with just a little snare like we saw. Then you would have to cut out a little chunk of the colon. So that's what they did. Okay, so then you would have to follow this patient up every few years with a colonoscopy, right? Okay, good. So does anybody have any questions on this one? Let's move right along to number 2. Okay. So this is telling us that our specimen is anal canal and rectum with part of sigmoid. So do you see this over here? This looks kind of squamous, right? And then this is clearly a line here. So this is our squamous mucosa. This is kind of a dentate line here. So this would be rectum through here, and then up at this end we might have a bit of sigmoid colon. So what do you see here? What do you see on this one? A lot of polyps, that's right. So that makes you think, well, let's just answer the question. Does that make you think this is sporadic disease, or does this person have some kind of a germline mutation predisposing them to polyps? Genetic, right. So what might this be? Very good, very good.
How would you know whether it was FAP or
The juvenile polyposis? So Lynch syndrome it's HNPCC, hereditary non-polyposis. So usually you'll have very few polyps, but they go to cancer. This one is the one that's just loaded with polyps. So if you see something carpeted with polyps like this, pick FAP. Okay, very good. What's chromosome? APCM5. Very good. You guys paid attention. Excellent. So this is saying, let's talk about the biology of the lesion. First of all, so we got all these polyps Now, what's interesting is they didn't do a whole colectomy on this, right? So who knows why not, why 4 or why not, but anyway. If this person has part of their colon still left in, what's going to happen to them? They're going to get cancer young, right? Very young, by age 30 or 40. And then how is this inherited? Is this X-linked, autosomal dominant? Very good. Okay. And let's see. Let me see what else I'm supposed to cover here. Okay. So what kind of signs might this person? So symptoms are something that the person relates to us, that they feel or they see. What are the signs? These are physical things that we see. What did you say? Yeah, that's actually a sign. You know, on colonoscopy, a jillion polyps, that's clearly a sign. So they may, I mean, I guess if some of these got so big that they could get ulcerated and bleed, they might have a little bleeding. But really they may be asymptomatic too, right? So the main way you would find this out is if there's a family member and the patient got tested or counseling or got scoped, then you would see all these polyps. Very good. Okay, and how would you treat this patient? Yeah, they should have a total colectomy, right? They should have their total colectomy. Okay. Where else can they get polyps? Where else can patients with FAP develop neoplasia? Endometrial? Where else in the GI tract? Yes. You got it? No? Not appendix? How about the ampulla? Yeah, the duodenum, and then stomach. So they can get it anywhere. They're at risk for these things anywhere, right? Okay. What about, what pathway would these go through?
Classic.
The classic pathway. Very good, very good. Okay, you don't need me here. You can do this. Okay. So this thing looks like a creature or something. The classic, the chromosomal instability, yes. So left obstructive is kind of sporadic. Right bleeding is if you have a right side of which is more MSI. FAP can be anywhere, you know, so because they have polyps anywhere. But if you had to pick one, it's more as a sporadic pathway. So, right. Okay. So here is a really ugly specimen, right? And we just never ever see these anymore. So this says anorectum and lower colon. So what? Here's the lesion. This thing here. This kind of shaggy, ugly thing. So what do you guys think that might be? If I told you that this is the lower, like rectum, lower colon, something that gets big and usually occurs in the very distal large bowel. Okay, I'll give you another hint. Yeah, this is, this is horrible. I mean, we just never see these anymore, but this is a big, shaggy villus adenoma. Now, I can promise you this thing looks huge, and so there's probably some invasive cancer hiding in here somewhere. But this is, we just never see these anymore because people get colonoscopy and get these biopsied and removed before they get this big. So here's this. So if you had to look at the size of this thing, would you guess that this is pre-malignant, not malignant, malignant? It's probably at least pre, right? At least pre to malignant, I would guess. Okay, very good. And then what about symptoms? So if you remember when you split something like this, when you fold it up, the diameter is compromised by however thick this is. So what kind of symptoms maybe did this patient have?
Obstruction?
They could have been, yeah, obstructed or partially obstructed because look how thick this is. So when you roll it together, it's going to leave a very small lumen, okay? When you have a small lumen, that's when people have, what do they call them? Like small caliber stool, things like that. These lesions in particular cause a couple of other symptoms. So because of this incredible surface that's exposed, you can lose with they have goblet cells and everything, which is mucin and protein. They can lose a lot of protein with these. So you can kind of wind up with a hypoproteinemia because of these. And they can lose a lot of potassium with it. So that's another thing that's kind of unique to these big villus adenomas. But again, we hardly ever see these anymore. Could it bleed? Yeah, this one's pretty big. So if some of this kind of got rubbed off by a stool or something, you can see how it could kind of ulcerate and bleed. Okay. We've kind of talked about, so let's see, we talked about our signs and symptoms. We think it's at least pre-malignant, if not malignant. The mucosa is extensively involved, right? And friability, do you guys know what that means, friability? Yeah, it looks like if you touched it, it would just kind of crumble, fall apart. This looks pretty crumbly to me. Does it look pretty crumbly to you? Yeah, so okay. So let's see, what else can we say? Okay, so I will tell you some things on my notes. They say it's shaggy. Okay, so yeah, I can buy that. This one was actually over 5 centimeters in diameter. That's pretty bad. And then they agree that there's probably a concurrent carcinoma in here somewhere, just based on the fact that it's a villus in this huge size. Okay, so the treatment of this would obviously be what they've done, right? They resect it out. There's no way you could biopsy this out. You'd be there all year. So just resect it and then follow the patient, right? Because if you've had one lesion, you're likely to have another. Good. Okay, what about, this thing is kind of weird. So, this one is number 4. So, identify and describe the polyp, polyp, and the cancer. So what's this thing? Yeah, what's this part?
It's a stalk.
Yeah, it's the stalk of the pedunculus. So this thing, here's the head of the polyp, this little thing flapping around out here. And this big long thing is the stalk. Okay. So then here's the mucosa. And this is pretty kind of normal for a fixed specimen, the color. And the pattern of folds is pretty normal for a fixed colon. And then you look up here at the wall, and it looks pretty much nice and thin, not too thickened or anything. Then you come down here, and what's this? It's been cut into, so it's kind of splayed out. It's kind of like opened up. But it looks like this edge used to be over here on this edge. So this is the thickness of the wall. So what is that thing? If it looks like it's going through the entire wall. Do you think it's benign? No, it's tumor, right? Invasive adenoma. Okay. So the depth is, it looks to me like it's all the way through the wall. And so out here, see this outside covering? This is our serosal surface, and it's right up here. So that's a highly invasive malignancy. So what symptoms might this person have had?
Obstruction.
Right, they might have been obstructed. Maybe some bleeding. Maybe they didn't want to eat, had weight loss, things like that. Okay, let me see. Yeah.
Is the term that you used earlier, is that like a real term?
No, that's something I said. Well, think about it. You know, you're just kind of out there flapping as it flows along.
It's
Yeah. Oh, you can't even quote me. I wouldn't care. They won't know who I am. So, but no, just, but see, it gives you a picture, right? Just kind of flapping out there. Yeah. Okay. And so remember we talked about these bleed, and so the person could have symptoms related to blood loss, right? They could have anemia. Remember, in an older person, if you have anemia, look for occult malignancy, right? So they could have fatigue, things like that. So, fecal breeze is just a visual image that I like. So, if I told you that this is a sporadic tumor, what's the pathway?
Classic.
If it's a sporadic tumor.
Classic, right?
Classic, right, with the APC. Right. Very good. Very good. You guys know this. All right. Cruising right along.
Even if there's only like just smaller.
What's that?
Even if there's only just one solid.
That's the first thing. So it looks like to me that this is a funky, like maybe they actually cut this out of here somewhere, or maybe this came from another resected portion of the valve. Yes. So the classic pathway is for patients with familial adenomatous polyposis or sporadic colon cancers. The MSI, microsatellite instability, is the Lynch syndrome pathway. It is really hard to think about these things. I agree with you. It is, to get your head around, it's really hard. Okay. Here's another one. So we've got, so this is an ileocecal specimen. So here's our smaller caliber ileum, right? Here's our larger caliber cecum. Here, it's hard to tell. I think there's two pictures with this one. Okay, here we go. What's that right there? This is kind of the ileocecal valve, right? And this thing is seated right down in the cecum. Here it's kind of spread out, so it looks kind of funny. They've kind of peeled it apart. Okay. So this is clearly a right-sided lesion, right? Does it look like it goes pretty deep? Kind of does, doesn't it? It's pretty full thickness here. So this would be clearly invasive malignancy. This one, what are 3 signs and symptoms? So this is right-sided. So maybe bleeding. Now on this one, remember we said if it's near the ileocecal valve and it completely occludes that, it could result in obstruction. These are much less common, but it could. So bleeding, fatigue, anemia, all that good stuff. Let's see. Would this one be, we don't see a bunch of polyps over here, right? So we're not thinking it's FAP. And if I told you this patient doesn't have any other strange history, this is probably the case of a sporadic tumor that just happened to be on the right side. It does happen. It's not as common as on the left, but it does happen. Okay.
How would you know that?
How would we know it?
It is a sporadic, just tumor instead of a Lynch.
So what we would do is we would do those 4 immunostains. And so when we looked at them, we would see that they would all be positive in the control, in the normal glands and in the tumor, because they haven't had a germline mutation and then another mutation, so they retain their staining. So if we have all 4, then that rules out a Lynch syndrome.
Okay, but without the immunostains, just tumor.
You couldn't do it, and that's one of the reasons why we started doing it, is because a lot of these are being missed. You know, or they probably happened in the past. I mean, it used to be, there's all these criteria, the Amsterdam criteria, the modified, you know, the Bethesda and all this stuff. And so you'd have to go by, you know, family members affected and different things, and have your blood tested for microsatellite instability. And now we're just like endometrial cancers in young women, you know, women under 40, and anybody with colorectal, we're testing them now. Yeah. So it's harder than it was previously thought. Okay, and here is a disgusting one. Okay, so here's, obviously we're kind of enlarged intestine. This is kind of usual configuration. Here's this thing. And then here's something down here. So it looks like some big kind of nasty tumor that's kind of all over the place, right? And if this were, if you tried to fold the lumen over or tried to fold it back, I mean, here's, okay, look, let's follow this. Here, this line is the mucosa. See how it goes up here, down here? Look at that. So this is the mucosa. This is something that's kind of between the mucosa and the outer surface. And if we come here on this side, we do the same thing. So right here, here's the lumen from like here to here. So you can see how that's really narrowed and strictured, right? It's really, you know, probably at least partially, if not completely obstructing. Okay, so that would be like an annular or napkin ring lesion, you know, where they kind of go around like that. Okay. What expose any person to one of these. Basically, a prior history of colon cancer, right, or some kind of, MSI or something like that. What about diet? High fat, low fiber, low antioxidant vitamins, those kinds of things. And our signs and symptoms will be kind of the same, right? Bleeding, maybe obstruction, maybe small caliber stools, fatigue, and the treatment's the same, resection, right? Okay. So is everybody pretty good with our colon cancers? Okay, good job.
For all of them, they were second.
Yeah, so what you do, so for any, for rectal cancers, they usually try to radiate them first. And so they resect, and then afterwards, based on, remember we talked about that stage, if they have positive lymph nodes and things, depending on how deep they are, they may get chemo and radiation